al doctor Eugene del Institute of Neurology del Houston Methodist. Él nos hablará sobre estimulación cerebral profunda. Soy candidato para esta terapia. Le damos la bienvenida al doctor Lai.
Good evening. I'm impressed by the large audience here that attending this meeting. First of all, I would like to thank Texalu and the hospital and the organizing committee to invite me to give this talk. I hope that in the next 30 minutes I can give you a summary of this innovative and new treatment for Parkinson's disease, that is deep brain stimulation. The question that my patients often ask me is that, am I a good candidate for this treatment? So first of all, I know a lot of you have the condition. I just want to introduce Dr. James Parkinson, who's a British physician who initially wrote the paper of spreading palsy. So you have the name. This is the person that you can associate with. He is the one that the disease is named after. So as Dr. Martinez have said, that the symptoms of Parkinson's disease include a resting tremor, stiffness we call rigidity, bradykinesia or slowness of movements, and then when the disease gets a little bit more advanced, the person have postural instability also. There are also some other associated symptoms with the 4 cardinal symptoms. So people will have smaller handwritings called micrographia, a low voice called hypophonia. Then their face will be lack of expression called hypomimia. Their walking will be shuffling, small steps, and sometimes they walk faster and faster and couldn't stop. It's called festination. They have some drooling of their saliva and also difficulty swallowing. So these are what we call motor dysfunctions. But at the same time, nowadays especially, we also know that Parkinson's patients also have multiple conditions we call non-motor symptoms. And these are the sleep disorders, autonomic dysfunction. They could have blood pressure fluctuations. They could have constipation. They could have gastrointestinal upset and problems, urinary problems, multiple frequency to go to the bathroom and so on. And they have sensory phenomena. Sometimes the muscles become so stiff that they would have pain and their foot can be turned to a certain way that will cause a lot of discomfort. Then they will have neuropsychiatric manifestations. Not uncommonly, 40% of our patients will have some depression and they have anxiety. That's very common. And then as the disease progresses, some of the patients will have some cognitive deterioration, some memory loss, and so on. So I take care of a lot of Parkinson's patients. Why is that? Some patients actually are very easy to treat. Their condition just progress very slowly. They are very amenable to treatment with just available oral medications that they take. But some patients actually progress pretty fast and they have more disability. And so some of the conditions that tell us that this patient is going to progress more rapidly is one is age. If the usual age for the diagnosis of Parkinson's disease is usually in the late 50s and early 60s. But if you have the condition older, like in the 70s or even 80s, then this condition is more difficult to treat. And then there are 2 main subtypes of Parkinson's disease. One is called tremor dominant. People start with a tremor. The other type is called PIGD, postural instability gait disturbance subtype. This involves about 30% of our patients that they don't show up with a tremor, but they have a lot of rigidity in their body and also difficulty walking and so on. Anybody who started having some memory deteriorations will signal to us that their condition will be a little bit more difficult to treat, although there are still treatments that we can offer. Very importantly, if the patient is not exercising, not moving around too much, just sit on the sofa and watch TV all the time, that's not good for a person with Parkinson's disease. We need to get them active, we need to get them exercising. And then also, sometimes if the Parkinson's patient did not get a neurological evaluation and treatment, they may do a little worse. So I would propose that anybody with Parkinson's disease should see a neurologist. So treatment options for Parkinson's disease include pharmacological treatments. Dr. Martinez has just mentioned that already. There are a list of options that we have. A neurologist and especially a movement disorder specialist will know how to use different medications to optimize the function of a person with Parkinson's disease. Then also very importantly, we have non-pharmacological treatments. That's what I was talking about. Exercises, it could be yoga, it could be Tai Chi, it could be dancing, anything just to get a person active. Or we offer physical therapy, speech therapy, occupational therapy. All these will help the patient a lot in terms of their functioning. And then lastly, if these treatments do not work as well, then we can offer surgical treatment. So when is the time that we start thinking about surgical treatment? And that's when the person starts having difficulties. Even if they take medication, their condition is not well controlled. Firstly, they have a dopa-induced dyskinesia. So when they take a pill, they are moving better. However, sometimes they move too much uncontrollably. That's called dyskinesia. Or they could have excessive tremor when the medication does not work. We call it an off state. A person gets excessive tremor, and sometimes even over the day, a person can have on-off fluctuation. That's sometimes the medicine works for them, sometimes the medication just totally do not have any effect on the symptoms of the patient. And then they could have very much pain, not controlled by the medicine, and then they could have walking difficulties, and the most difficult one is the freezing. They would walk a few steps and all of a sudden they cannot move their feet anymore, and then that leads to falling, certainly will create a lot of disability. So surgical treatment in Parkinson's disease can be electrical stimulation, that is deep brain stimulation, or ablative surgery. We just make a lesion in the brain, use some heat to burn the hole there, almost like creating a small stroke. Dr. Salazar will talk to this a little bit more in detail. I'm just going to introduce the topic. And so deep brain stimulation is indeed a revolution in the Parkinson's treatment, because in the past, because Parkinson's disease is a condition that the brain lacks dopamine. The brain starts not making dopamine, so the treatment is to give back the patient more dopamine. But this DBS treatment is that actually we know how the brain works and where are the nerves are connected, and we actually put the electrode in a place that would modulate the functions of that different parts of the brain without using drugs and just using electrical currents. And it is really a paradigm shift, a totally different concept in terms of neurological therapy. So deep brain stimulation is essentially a high-frequency pulsatile electrical stimulation, giving some electrical currents to a certain part of the brain. It is stereotactically placed into the target nucleus. It can be activated or deactivated by a minute. So the good thing about deep brain stimulation is it could be turned off, it could be turned on, it could be adjusted according to a person's need. Or as the disease progresses, a person gets more disabled, we could adjust the stimulator to control the progressing symptoms. It is also a reversible condition if later on we have a better treatment than deep brain stimulation. We could just take the stimulator out without causing too much damage to the brain at all. So the exact physiology of the treatment is unknown, but the higher frequency really mimics stopping some of the, or reducing some of the excessive functions in the brain, so allow the person to be free of this stiffness and slowness so they can move faster and they are less stiff. Just a diagram to show that there are actually two thin wires that the surgeon inserted into a specific part of the brain, and it is linked with a wire to a pulse generator, something like a pacemaker that is attached here in the chest. Everything is enclosed and under the skin, nothing is exposed, so a person can, swim, can shower, without any problem at all. And we use a minute to regulate the stimulator. This just shows, as it was just shown you, the picture of the brain. This is a cross-section of the brain showing that the stimulator is put into the very deep part of the brain. There are three specific targets that we recommend for deep brain stimulation. One is the VIM, or ventral intermediate nucleus of the thalamus. That's mostly for tremors. And then the one is called subthalamic nucleus. The other one is called globus pallidus internus. So we use these two locations to put the stimulator in, and I know that we will discuss it a little bit more. So as you could see from this X-ray, the wires, very thin wires, are actually inserted into the deep part of the brain, and the wiring will come out and be placed underneath the skin. So for patients with Parkinson's disease, and you are considering deep brain stimulation, what are some of the things that you need to think about? One is, it is not a cure. It is still a symptomatic treatment, but it's a very good symptomatic treatment if the patients are suitable for this particular surgery. Bilateral placement of the electrodes are often required to improve both sides of the functioning and to improve gait. And it smooths out the on-off fluctuations in the person. That is the most disabling and anxiety generating for the patient, because sometimes they take a medicine, it works. Sometimes they take a medication, it doesn't work. So they, all through the day, the patient just doesn't know when they can actually take a shower or go eat and so on, that are very much anxiety generating. It improved the tremor, the bradykinesia, the slowness, the rigidity or the stiffness, and the dyskinesia, the involuntary movements that a person has. In most cases, but not completely eliminate them. So for some patients, we could talk about it later, if the stimulator is put into exactly the right position, it works very well. If it is slightly off the center or off the target, then it is more difficult for the neurologist to have to adjust the settings to compensate for the slightly off location of the placement of the electrode. It does not improve some of the symptoms that are not improved by levodopa. So if a person takes the medicine and you still can be, the best you can do is what the stimulator will give you. So if a person cannot walk, even if at their best medical treatment, then the stimulator still would not make you walk. Okay. Then programming visits are likely to be quite a few times in the initial 6 months. So you have to prepare to visit the doctor and be patient. So there are some fine-tuning of the stimulator that is necessary to get the best setting for the patients. And then lastly, it decreases the medication in many persons, especially for people that really have a lot of side effects from medications. Deep brain stimulation also is a good option, and we can reduce the medication, but not to all the patients. So what is the importance of finding the right patient for this surgical procedure? Because more than 30% of the failures in DBS is due to inappropriate patient selection. We choose the wrong patient, go through all the surgery and the expense and so on. It doesn't help the patient. So that's not something that we want to do. So we want to be, before we actually do the procedure, we want to make sure that there is a good chance the patient will benefit from it. And there is really no universally accepted way to say this is the right patient or that's the wrong patient and so on. But from experience in Houston Methodist Hospital, we've been doing this for almost 20 years, so we have a lot of experience choosing the right patient and working with the neurosurgeon in doing the deep brain stimulation. Understand that deep brain stimulation is an invasive procedure, so not all patients are suitable for that. However, if it is a suitable candidate, if I said that you would benefit, because I'm a neurologist, I am quite neutral. I don't do the surgery, so I would have to refer you to the neurosurgeon. So if I think that you are a good candidate, I'm quite confident that you will benefit from that. However, so DBS will improve the motor symptoms. One thing to remember, that is the slowness, the stiffness, the tremor, the involuntary movements. But it really have not that much effect, especially on the speech and the balance and so on. And especially any of the non-motor symptoms, it does not help that much. We still need additional medicine for our patients. And DBS also may worsen some of the neuropsychological functioning, such as depression and cognitive deterioration. So sometimes after the procedure, especially for patients that are already quite depressed and also they have some cognitive impairment already, then this may potentially worsen them. So a potential good candidate for deep brain stimulation is to have the idiopathic Parkinson's disease. That is someone that do not have a genetic predisposition, the condition doesn't run in the family, and should be confirmed by a movement disorder specialist. We usually will choose a patient at least have 5 years of symptom onset, because in the first few years, sometimes even we would think that this person likely have Parkinson's disease, but as a person gets a little bit more advanced in their disease, we will see that there are atypical features that actually points them to an atypical Parkinsonian, some mimickers of Parkinson's disease, not real Parkinson's disease. And hopefully the patient is less than 75 years old. We do surgery up until 75. Actually, we did some over 75 years old, and most of them do very well. But as you get a little older, your brain shrinks down, and the neurosurgeon will have more difficulty, pinpointing the location of the target to place the stimulator. Good response to levodopa, so at least at one time they respond to this medicine levodopa very well. And then later on, of course, they could be having more difficulty responding. But at least at one time, we want to get the history that they are very much better, especially in the first few years, that almost turn them back to their usual self when they take a little bit of the medicine. There's a home and yard disability scale, which means that at stage 3, that a person have difficulties on both sides of the body and a little bit of balance problems, but they can still walk by themselves, and they would not need a cane or walker, at least for a few steps to walk. If a person's already in a wheelchair and have a lot of walking difficulty using a walker already, then deep brain stimulation may not help their walking at all. And the major disability are, again, the motor symptoms, the motor fluctuations and or dyskinesias and or the tremors and so on. And they should have normal or really just minimally affected cognitive and psychiatric or behavior status, and no serious comorbidities, overweight, diabetes, heart problems, and so on. Not serious ones. A little bit of that is okay. It's very important that patients and their families are well informed about the risks and benefits of this condition. It is a surgical procedure, but it's a minor surgery procedure as far as brain surgery is concerned, but still carries some risk, and we have to be realistic as to the what symptoms it would help and what symptoms it will not help in this patient. And also needs the cooperation of the patient, that you have to come back several times after the placement of the deep brain stimulation to make sure that we can adjust it to the right level to benefit the patient. And if we have support from the family, friends, and so on, that's even better. So in contrast, who is not that suitable for Parkinson's disease? So if they have atypical Parkinsonian symptoms, what I mean is that they have atypical Parkinson's symptoms, or their age is older than 75, and they have a history of not really responding well to the levodopa, or they have already been, just as I said, already wheelchair bound and very difficulty walking. They have to have a walker or people helping them to walk. Major disabilities actually are walking problems, instability, falling, and speech difficulties. These, as I mentioned before, are not very good symptoms that deep brain stimulation can help. If they are already cognitively impaired, memory loss and so on, or they have significant depression, the deep brain stimulation can potentially worsen their condition, so we usually advise them not to have the procedure. Behavioral problems such as hallucinations, agitations are okay if it is a response and just a side effect of the medication. But if it is just, without the medication, they still have that, then we have to be a little bit more cautious about that. If they have major problems, serious comorbidities, and unrealistic expectations, these are also not suitable. So in the Houston Methodist Hospital, when a person comes to me to say that, I want to consider deep brain stimulation, first of all, we will do a consultation with me. They would come in their off state, that is not taking any medicine since midnight, and I'll see them at 8 o'clock or so, to see how they are when they are not with any medication. And then in the clinic, I'll give them some medication and to see how they do when they are on medication to confirm the diagnosis. Then the patient and their family are given educational material to have them review and think about that. They need to complete a comprehensive neuropsychological evaluation. Again, we want to make sure that their cognitive function is not too bad, and their psychological problems such as depression are not serious. And then they would return to me, and then we will discuss and answer their questions as about the procedure. Then I will refer them to our neurosurgeon, Dr. Richard Simpson, who has done more than 1,000 of these conditions very successfully. And then they would schedule the deep brain stimulator surgery. Usually within a few weeks, they could have the surgery. The surgery in at least our hospital is divided into 2 stages. The first stage is to place the electrode into the brain. We need 2 small holes in the front of the skull, and then the surgeon puts the thin wire into it, and then the extra wiring, they put it underneath the skin. Then we will wait about a week or so, and then have the patient come back, or the patient usually just stays 1 night in the hospital, and then the next day they can go home. And then 1 week later, they will come back, and then we would place the pulse generator, like a pacemaker type of device, to be hooked up to the wires so we could have the whole system implanted. Again, we will wait another week, allow the incisions to heal, and then the patient then will come back to me, and my assistant and I will start turning on the stimulator, adjust the stimulator, and patients will almost have immediate response, to the benefits of the stimulator. But also, like I said, the first time we just have a one-time thing, and then after a couple of weeks, we will fine-tune it a little bit. Usually in the first 3 to 6 months, we have to come back maybe 2 or 3 times to do some fine adjustment to make sure that the setting is the correct. So I just have a few videos before I conclude. You see, so this is a good patient for deep brain stimulation. Why? You can see that this is when he is off medicine, that's not taking medicine. He has, of course, a very blank face. He's very stiff. He shakes. He really, have difficulty taking care of himself. Okay, next slide. And then when he walks, and you can see that he has shuffling gait, but he can still walk, by himself. So that's what we want. This is a 60-year-old man. He has Parkinson's disease for about 10 years already. And now he takes the medication. So his problem is that, yes, the medicine helps, but then he has the dyskinesia, the involuntary movements. I apologize for the fuzziness of this video. We did not focus it right, but you could see that he has a lot of movements that are involuntary, sometimes interferes with his activities of daily living. But when he's good, after about 30 minutes or so, you could see that with the on medication, he is back. So like I said earlier, the best I can do for the patient is their best when they are on. So this is what we hope to achieve after we put in the stimulator, at least get their on and off periods equalized. So this is about 5-6 months after his deep brain stimulator. You could see that even his facial expression, he is on stimulation and no medicine at all at this time.
Good. Stand up.
And he can stand up, he can walk, you know.
Good. Turn around. Okay. Walk towards me one more time.
Right. So it's, you know, a very good response to the medicine. This is a lady in his 60s that have a lot of dyskinesia. So, and you can see that this involuntary movement just disabled her. So if she does not take the medicine, she cannot move. But if she takes the medicine, she's just moving too much and she just cannot stop, you know, in terms of that. Okay, so this is with the stimulator on. You can see that at least she is a lot.
Today is a nice day.
Today is a nice day.
Good. How are you
and
feeling
her voice
today?
is clearer too.
Well, I was feeling a little wobbly, but it's gotten better.
Okay. Now, can you put up your hands for me in front of you?
Okay.
So no more dyskinesia, as you could see. But he can, she can get up and she can walk now.
Oh, very good. And walk a couple
I was
steps for
surprised
me.
by that too. Yeah. Okay. Still a little slow, but pretty good. This young lady have really young onset Parkinson's disease, and she has a tremor, as you could see, and difficulty to control. It is an irregular type of tremor. We spend a lot of time trying to fine-tune her deep brain stimulator. And now with the stimulator on, as you could see, that at least the tremor, although it's not totally gone, it's a lot better.
Okay, put your hands up. Okay, turn it on, turn it around.
Like this.
Yeah. Tap, tap, tap.
Okay, so this is when she walks, and you could see that she is really doing very well after the deep brain stimulation. So my last slide is, these are some of my recommendations. So a good candidate, patients with Parkinson's disease and with disabling motor fluctuation and or dyskinesia and or intractable tremor, but without significant cognitive or psychiatric problems. So that's one thing that we are looking for our patients. The deep brain stimulation should be performed at centers that has a experienced team of experts, so that such as in Houston Hospital, in Houston Methodist Hospital, or in this hospital, Dr. Salazar will tell you a little bit about their team, that their experience also. Both the STN and the GBI targets are equally good, equally effective in treating the motor symptoms. And all it depends is the surgeon's confidence in putting the stimulator and the preference of the patients, that's all. So lastly, the DBS treatment is primary for dopa responsive symptoms. So anything when you take the levodopa, you get better. That is the symptoms that the patient will improve with deep brain stimulation. But it is not for all the symptoms of Parkinson's disease, unfortunately, at this time. We still need medication. But one thing we know is once it is good, it will last for quite a few years. Now we have patients more than 10 years after the placement, and they are still doing pretty well. That's all I have. Thank you very much.